Jared, is it okay to get started?
Yes, good, go.
Okay. So we have about 100 registrants, and I'm not sure how that will end up as far as people jumping on, but there should be some more people joining. But we want to respect your time, and so let's get us started. So my name is Eric Muschler. I'm the Director of Housing and Health Equity at the Greater Minnesota Housing Fund. And the Housing and Health Equity Initiative does these events to build cross-sector knowledge and partnerships. So we like to make connections, we learn from examples, it helps to spark ideas and innovations, and we encourage more cross-sector collaboration. Today, we're very lucky to have the Build Healthy Places Network as our co-sponsors. They are a national organization at the intersection of community development and healthcare. So the agenda for today is some time to learn a little bit about the Healthy Places Network. Then they will actually do a panel interview with a couple of examples of healthcare involved partnerships from the Rural Playbook, which is a collection of stories from across the country. And we're going to feature a couple, one from Idaho and St. Alphonsus Health System, and another from Pierce County, Wisconsin Health Department, which is right across the St. Croix River from the Twin Cities. So we're really happy to have them. And then we'll have John Rocker, Director of Lending at Greater Minnesota Housing Fund, share some Minnesota examples and, and ways to be a catalyst in creating affordable housing in your community. So we will encourage questions from the audience. If you put it in the chat, we're going to be collecting those so that we have them in the end and we can bring them back into the question and answer period. So what I'd like to do now is introduce the Build Healthy Places Network. Ashley Hernandez, Communications Manager, and Jen Lewis Walden, Special Advisor to the Build Healthy Places Network. And they'll share more about the organization and the stories and tools available to help you do your work. So Ashley, Jen, go ahead.
Thanks so much, Eric. I'm going to get us started and then I'll pass it over to Ashley in a bit. We're really excited to be here. I'm Jen, as Eric mentioned. I'm an advisor with Build Healthy Places, and Ashley is with me today, Research and Product Manager with the network. And as Eric mentioned, the Build Healthy Places Network, we're a national center and we sit at the intersection of healthcare, public health, community development, and finance sectors. And we're working to improve health and well-being in communities across the country and really fostering cross-sector partnerships to more effectively reduce poverty, advance racial equity, and improve health. Next slide. We focus specifically on this intersection of community development and healthcare because the opportunities are particularly ripe to leverage the assets of each of these sectors to benefit the same neighborhoods where they're both working. Community development is building wealth and prosperity in the same places where healthcare is really growing their investments focused on the upstream drivers of health, the social determinants of health, in historically under-resourced neighborhoods and communities. So we see an opportunity to align those efforts, really leverage resources and deepen commitments to place-based work. Next slide. Healthcare in particular is very well positioned to make meaningful contributions to healthy places. And there are a diverse array of levers available for direct resourcing of healthy communities, fostering partnership, using influence power. We'll hear a few of them today during the panel. For example, many healthcare organizations are deepening anchor institution commitments. In other words, seeing a win-win opportunity to procure goods locally, hire locally, and creating wealth in communities where they're rooted. Additionally, healthcare is growing a role in leveraging land holdings and real estate. We've collected lots of examples in our tools and case studies of healthcare participating in projects involving land donation, land swaps, co-location of services, and other creative ways of using real estate and land holdings. Of course, we also see healthcare making loans, grants, direct investments in projects that create the community conditions that generate health, like housing projects And like we'll also hear today, we see healthcare leaders taking an active role in the public policy process as well to expand opportunities for affordable housing. Next slide. I just want to highlight some of our resources that Build Healthy Places Network has produced. We host a website that has a lot of resources, tools, and case studies that really are at this intersection of cross-sector partnerships for health. We have a listserv as well, where we send out new resources on a regular basis. Next slide. Some of those examples, we have a series of fact sheets. The ones highlighted here focus on the community development sector's role in addressing challenges like social isolation, homelessness, and mental health. The fact sheet series is sort of a quick snapshot of the evidence base, some case studies of cross-sector partnerships, and aims to make the case for deeper collaboration. The next slide. We also have community close-ups. These are in-depth case studies. They really break down the mechanics of how specific partnerships came together to understand how to operationalize these kinds of partnerships. They explore who the communities are, stakeholders involved, specific facilitators of project success, and even get into the details of how the financial pieces come together for specific projects. And finally, in terms of tools, we also have very in-depth tools that help support multi-sector partnerships, maximize the unique aspects and assets of each of these different sectors. And they always apply an equity lens to ensure that there's an equitable approach to multi-sector partnerships. For example, we've created tools to advance public policy. We created a national scan, the Healthy Neighborhood Investments Policy Scan, that looked at federal, state, and local level policies that are being implemented across housing, education, health, social services, transportation. And then we've done a deeper dive of public policy opportunities in specific places like West Virginia and Wisconsin that you'll hear about today. And then we've created a number of other tools that are specifically at this intersection of community development and healthcare. So the one that we'll highlight today is on rural healthcare investments, using multi-sector approaches to advance health in rural communities. On the next slide, so this particular tool that we will highlight today really is going to focus on how rural partnerships are advancing health, and a set of case studies specific to healthcare investments in housing. These types of investments are expanding across the field as hospitals and health systems are seeing the value, both in terms of health and also the bottom line of addressing the root causes of health, including housing. And with that, I'll pass it over to Ashley to go deeper into the Rural Playbook.
Thanks so much, Jen. Next slide, please. So as Jen and Eric mentioned, Build Healthy Places Network recently published a playbook called the New Rural Healthcare Partnership Models for Investment. And really, we set out to explore the work of healthcare partnerships in rural communities because broadly, there's a lot of rapid change happening in rural communities. And certainly there are challenges, but there's also significant assets that health partners can tap into in order to address inequities in rural spaces. So for example, partners can tap into the interconnectedness and close-knit ties that already exist in rural areas and utilize those informal networks to create bridges between formal sectors. Partners can use these natural networks to address challenges in rural places like attracting capital. And as we will see today, in an example, even small investments can make big impacts. And that interconnectedness can potentially provide access to rich community knowledge that really should be driving some of these solutions. Next slide, please. So therefore, the playbook and other tools that we've published lean on two frameworks to guide a holistic and equitable view of how change can happen. First, we leverage the vital conditions for well-being and justice, which you'll see on the upper left-hand corner of the slide. And it spans the core components of what makes up a healthy community and places where we can invest. We couple this with the spectrum of community engagement to ownership, a tool that really helps us ensure that we are using community knowledge to deepen the ways that community leaders and residents have a voice and agency in shaping investments, policies, and projects. Next slide, please. And so these frameworks were supported by what we identified as cross-cutting themes that really emerged from interviews that we conducted with practitioners for the role playbook. So one primary theme was the importance of trust and relationship building in advance of making an investment, because engaging in an inclusive process is necessary to craft a shared vision of prosperity and health that works for one particular community. And part of this process really requires us to pause and intentionally interrogate where there may be biases, policies, or practices that are excluding some groups more than others, which of course hinders trust and prevents all residents from crafting that shared vision that really helps ensure that everyone benefits from a project. And again, we'll see a little bit of how this played out in an example today. Next slide, please. So likewise, from these interviews, 4 broad strategies emerged. Successful partnerships across the field demonstrated these strategies, such as strengthening workforce and economic development, situating control locally, strengthening infrastructure, and increasing investments. And to be clear, many of the projects or case studies featured in the role playbook didn't sit neatly in one of these buckets. In fact, they touched on multiple, but what we found when we put together the playbook was that these strategies are helpful in conceptualizing the work and the possibilities when we embark on these partnerships. Next slide, please. And so I do want to mention that the case studies in the playbook come from across the country. So in fact, this map is a map that illustrates where all the different projects took place. And these examples really illustrate how different multi-sector partnerships are adopting these strategies and cross-cutting themes throughout the country. So you can actually take a look at our playbook to read more about the specific projects. Next slide, please. And so for now, we are excited to highlight 2 partners leading this work in the field. So first, we'll learn from Rebecca Lemons from St. Alphonsus Health System. And Rebecca is going to talk about how St. Alphonsus invested in Idaho's very first land trust, creating single-family homes that would remain affordable in perpetuity while providing a pathway for homeownership. And then we're going to learn from AZ Snyder from Pierce County, Wisconsin. So AZ is going to be sharing about a local policy scan that was recently completed by a multi-sector coalition to identify affordable housing policies that can be implemented in rural Wisconsin. And so with that, I'm actually going to turn it over to the panel. And I'm first going to ask Rebecca to please introduce yourself and the work, you as a healthcare leader, and how you spearheaded through St. Alphonsus, the first land trust in Idaho.
Absolutely. Well, good afternoon, everyone. Thank you so much for letting me join you today. My name is Rebecca Lemons. I'm the Director of Community Health and Wellbeing for St. Alphonsus Health System. I'm based in Boise, Idaho, but I serve from Boise all the way over into the rural and frontier communities in Eastern Oregon. So we have a pretty interesting and broad swath of communities that we work in, from urban, we think we're a big city, but we're not a very big city in Boise, to suburban, to rural and very frontier communities. And one of the things that I can share about how we came as a hospital system and a Catholic health system to housing is a couple different pathways. A few years ago, we started identifying that housing is healthcare. And we started with our 2020 community health needs assessment. For the very first time as a hospital, we went out and we were doing our listening sessions and our surveys and our focus groups and our deep community listening. And for the first time, healthcare access, obesity, diabetes, nutrition weren't on the tips of people's tongues. It was housing, housing, housing. My rent is going up. I'm struggling to find another place to live. There's not a lot of rentals in our area, and I definitely can't afford to purchase a home. And this was 5 years ago. And Boise ended up becoming one of the fastest growing housing markets for the previous 5 years. So though we're small, people caught on that we have a beautiful community and it was pretty affordable to live here. but it was putting a strain on the folks that had been here for a long time. And when we have a minimum wage of $7.25 an hour, being able to translate livable wages into housing affordability was becoming difficult even in 2020. So it was the first time as a health system, it was a wake-up call to have our community saying, accessing healthcare is the last thing on my list right now. Rent eats first. And so we said, okay, what can we do as a health system? How can we lean in? And so we started establishing a number of different housing projects and different ways that we could, as a health system, be a meaningful partner in housing. As a public health professional working in a healthcare space, I had a lot of learning to do, but that's where the power of collaboratives really come to play. So we were excited that one of the very first opportunities that came to us was the opportunity to do the very first land trust, housing trust for Idaho in LEAP. And so the idea was that we would be an initial investor into this housing trust fund. LEAP Housing Solutions was our nonprofit partner. They were a nonprofit arm of a for-profit real estate development, and they had an opportunity where we could help purchase some land underneath 14 units of single-family homes to become affordable housing that would stay affordable in perpetuity per the land trust model, which was something brand new to us. So we were very eager to lean in and make this land trust our first housing project, but also the first housing land trust in Idaho, which by the by has become very popular now. So we were excited to begin to see it grow off the bat.
Thank you, Rebecca. And AZ, could you please introduce yourself and the work as a public health leader, and tell us a little bit more how the Healthier Together Coalition was able to advance affordable housing policy efforts in your state.
Sure. Good afternoon, everybody. So my name's AZ. I'm the Public Health Director and Health Officer for Pierce County, Wisconsin. My background is in epidemiology. I am not an expert in housing, and public health doesn't need to be involved. We don't need to be the expert, but public health, your local health departments are really great conveners to bring partners from across sectors together. Your health departments very likely have strong relationships with other county health departments, such as land use and development, municipal leaders, hospitals, nonprofits, service providers, and economic development agencies. Health departments should really be used as a focal point to help convene some of those conversations. So a little bit about Pierce County. We are technically part of the Twin Cities metropolitan area. In case you've never heard of us, Minnesotans, cities like River Falls and Prescott fall in Pierce County. And even though we're part of the Twin Cities area, technically we are decidedly rural in identity. So our main export is cheese curds. We have about 42,000 people in our beautiful county, including a University of Wisconsin campus that focuses on agriculture. So Healthier Together was formed about a decade ago, and it's currently led by 4 hospitals, including 1 independent rural access hospital, Western Wisconsin Health, the Allina Health System, and 2 Health Partners hospitals, 2 local health departments, so we're a bi-county coalition, and United Way of St. Croix Valley. So much as Rebecca kind of noted, in previous iterations of our CHA-CHIP, we were very focused on mental health, substance use, physical activity, nutrition. But really during the pandemic, things started to shift for us to really realize we really need to look at these upstream social determinants of health. And based on community feedback, one of our priorities is now thriving in livable communities, where we're really focusing on childcare, access to affordable, high quality childcare, as well as access to housing. So housing really, it was a problem before the pandemic, but I think it came into really sharp focus during the pandemic because it became very clear to those of us working in public health and healthcare that people were being placed in situations in which they were at higher risk for infection or spreading infection to others because of housing instability and overcrowding. And it really unveiled a lot of hidden housing insecurity in our rural area. So it would be unusual to see someone sleeping on the streets in Pierce County, right? And that may not be true of all of our urban areas. But through conversations with people, often who had been identified as positive for COVID-19, we were finding that people were doing a lot of couch surfing, staying in unheated RVs, a kind of bopping around from relative to relative, and that a lot of that housing insecurity was really hidden in our community. As I mentioned, we're really just at the beginning of our housing journey, but United Way of St. Croix Valley and Allison Sauter from United Way is on this call, wrote for and won a just response to the pandemic grant, which is CDC funds supported by the Wisconsin State Health Department to support a housing assessment, because we really felt like we needed to just first of all, get a baseline for what the housing situation is in Pierce and St. Croix counties. So in partnership with Build Healthy Places Network, because we are not housing experts, we just completed a housing policy scan to understand what work like Rebecca's has already occurred in similarly sized communities with similar demographics. And we really focused on a couple major areas, but through our stakeholders really found that they were interested in workforce housing for sure in our rural communities, and senior housing, as well as co-location of services and wraparound services related to housing. And this assessment was really fantastic in helping us deepen our understanding of how to approach policy change in a way that's really centered in engagement and community trust building. So as I mentioned, we were really looking for policies because oftentimes, if you're from a rural area, you see these fantastic policies that worked really great in Boston and New York and LA, and you're like, well, that's never going to fly in Pierce County, Wisconsin. And bringing this policy as an example might even end the conversation, because if I'm like, look at what Sacramento did, the Pierce County, Wisconsin leaders are not going to want to hear about that. So we really looked for policies that were successful in similar areas. So targeted working families, were in rural areas, were supported in a bipartisan way, and potentially had easy wins. So the areas that I focused on the most were really accessory dwelling unit ordinances that made it possible and equitable to have accessory dwelling units, which are often called granny flats, on people's properties, which could be used to help communities build wealth. It can also be used to house seniors, and we have a large population of college students in our area. And we also looked at land trusts. So we haven't implemented any of that, but those are some of the really wonderful examples from other communities that we're currently exploring.
Thank you, AZ. So I'm going to go ahead and kick off the first formal question of the panel. And this is for you, Rebecca. And you did already touch on this, but if you'd like to expand, what were the key motivations or pressure points that spurred St. Alphonsus to pursue housing investments? In particular, why the land trust model? And what were the benefits of engaging cross-sector partners? And would you do anything differently?
Great question. So the housing trust model was fantastic because we were able to dip our toes in the water of housing for the first time. 5 years ago, my CEO of our health system hadn't really invested in a project like this, let alone anything related to housing that wasn't hospital specific. We knew we didn't want to be landowners. We knew we didn't want to be landlords. And we knew that at the time we didn't have any land of our own to contribute towards housing. And so as we thought about what does it mean to be a meaningful partner in housing, we were a little bit limited in what we thought we would be able to do, and it was so new to us. So it was really great that this land trust option was an option where we could invest an initial amount. So in our case, it was $250,000, which was a lot for us. And that purchased the land price for 6 of 14 single family homes that were developed specifically for families that made 60 to 80% of area median income in the Boise area. And this particular development was built in suburban Boise, which may not feel rural, but it gets us on that pathway, and we'll get to the rural piece. So it was a toe in the water because we were able to put in our initial investment, and we liked that one, it created a pathway for home ownership. Our leadership was really interested in this idea because in Boise, all of the affordable housing projects we've been otherwise working towards were multifamily. It's a lot of big developments with lots and lots of units, but there was not a pathway for folks in our community to be able to purchase a home of their own and build mobility through equity and to move on into other future home purchases. It was just completely unattainable. So the idea that while this is a smaller number of units to start off with as our first project, it created a unique place in our market that didn't exist for first-time home buyers or other folks with limited income means to be able to invest in their housing. And so the homeowners in the land trust are able to purchase the home while the land trust holds the land underneath it. And then they are able to then sell the home and take the equity with them, but it keeps that home for future purchases in an affordability price bracket that keeps it affordable forever and ever. And so between having single family homes, allowing people the opportunity to purchase homes and take on equity and mobility in their economic movement, and the ability to leverage our dollars for something that was going to be available in perpetuity, all of those things made it kind of the perfect project for us to start with and very appealing to our leadership. The next step in that process was our $250,000 was great, but if you know anything about housing, that was not at all the amount of money that needed to be raised to cover this entire development. So we were able to use our name as a locally recognized and trusted Catholic health organization to talk to others about why we were doing housing as healthcare, why we liked the land trust, why we thought this was an innovative model. And with that, we were able to secure a total of $2 million in partnership with LEAP for a housing land trust that ended up growing. So it ended up not just being the initial 16 homes, which all now have owners and they are all fully occupied at this point. It's really exciting to drive by and see it, but they were able to extend the land trust to include an additional housing development in Mountain Home, Idaho, which is rural. It's a home of an Air Force base, so another area where it's hard to find housing opportunities outside of the Air Force base. And now LEAP has even taken it a step further and done a statewide $5 million land trust as their next thing. But we were able to kind of use our dollars to leverage into others. So it was really nice to be able to start telling the story from the hospital perspective, but to get other people in insurance and in education and in the business sector to say, this is really important for all of us. We all are having workforce shortage issues. All of our colleagues are struggling to find places to own. And so this really helps us to be able to do that. In terms of the partnerships, what was really lovely is that LEAP played the part of all things housing. Just like AZ said, I'm not a housing expert. I've learned a lot in 5 years and I know enough to be dangerous, but I'm not a housing person who does financing. They had to explain it to me like cake so that I could understand. But it was great. So LEAP came along and they explained to me housing financing and different options and opportunities for housing. They led the charge on getting other people to put the money into the trust and the operations of it and making sure it's all done and coordinated smoothly. So they really helped us understand how to do those things so that we could have a little bit of separation from the project. We wanted to participate, but we didn't want to be those landowners. Or things like that. So we really enjoyed that they played that role. We played the role of kind of going out and talking to other entities about why this is important, why this was a good investment. And we ended up becoming the model for how others, including the city of Boise, could now do their own land trusts, so that we're starting to see this become a viable option happening all across our state in rural and suburban areas, which has been really fantastic. So in terms of that, I wouldn't change anything. I think having that collaborative was really important and has actually laid the groundwork for a lot of projects we're doing even into today. We recently announced that St. Alphonsus is partner in the Build Health Challenge cohort number 4, not Build Healthy Places, Build Health Challenge cohort number 4. We will be doing housing, community engagement, which I'm super excited about, community champion building and advocacy, and shared services in Payette, Idaho, which is a very rural community of 8,000 people on the border of Idaho and Oregon. That is going to be by far the smallest and most rural community that Build Health Challenge has ever invested in. So we're excited to use all these lessons we learned about collaborative work and, you know, dipping our toes in the water of housing to bring to other communities in our area as well.
Yeah, lots of exciting work happening, Rebecca. And you mentioned that the land trust is expanding into rural parts of the state, such as rural Mountain Home. So what are the challenges in investing in affordable housing in a rural area? And how did you find a workaround to address those challenges?
There's a number of challenges in working in super rural areas, but to your point at the beginning of our discussion today, you talked about the beauty and the benefits of relationships in rural communities. We joke that even in Boise, which is the big city, everything is 2 degrees of separation. Somehow I know someone who knows you, who worked with your dad, who, knows someone. And so building relationships with people was the critical first step in getting involved in rural work of any kind, whether it's housing or any kind of community or public health initiatives. And so honestly, when St. Alphonsus first started getting interested in housing, we had coffee chats with people. I was incredibly vulnerable and honest and said, hey, I'm this person who has deep passion for public and community health, but I don't know anything about housing. Can you explain it to me? Can you explain to me the financing? Can you explain to me different options? I really want to invest in something that is mission driven to meet our organizational mission. And so we were able to have these literal coffee and lunch conversations with a number of different partners one-on-one. And that's how really organic projects came to be. That's how the LEAP Land Trust came to be. When I met with LEAP and asked them to explain to me what a housing land trust is, then we talked about this opportunity. And now we're going to work together in Payette because I called them and said, hey, I'm thinking about doing something over toward the Idaho-Oregon border. What do you think? And they said, yeah, actually, we're really interested in Payette too. We're going to go ask a bank for some land. Do you want to join? And I'm like, yes, I do. So it's building these trusted relationships with individuals and leaning into these natural and organic opportunities to go where there's some momentum. So leaning in where people are already willing and excited to do a housing project, but think about what else, right? And that's what we bring to the table, is having open conversations about. In Payette, for example, the mayor told me, I don't just want sticks and bricks. We've got enough housing. And I said, well, that's not what we want to do. We want to engage the community to develop services that would be offered on site to the residents. We really want to make it a holistic approach to housing and services. So I think being able to build those relationships, framing this investment as workforce housing is another way to do it. What we're finding is in some of our more conservative communities, even saying affordable housing sometimes is a red flag for folks, to AZ's point, right? What works in one community does not work in another. And I can't always say affordable housing. So now we're saying attainable housing or workforce housing or reverent housing, depending on the community or the audience that we're working in. And I kind of bend, when you talk to a housing developer, workforce housing means one thing. I don't use that definition. Everything is workforce housing. Everyone is working, trying to support others that work. So I used workforce housing very liberally in my speaking. And so we've been talking about why we need housing as a method of workforce. So sometimes it's also learning the culture and the language and being able to adapt so that you're saying to get to the intent of what you want to do, but you're honoring and understanding the culture and the will behind the folks that you're working with. So building the relationships, talking the right talk, framing it in the right way to bring others along with you, showing how it's going to lean into the growth of the community. And then finally, I would offer that in these rural areas, one of the roles we play first and foremost is combating NIMBYism, or not in my backyardism. One of the biggest challenges in rural communities is there's a deep stigma and misunderstanding of what affordable, attainable, reverent housing is. They think of old school, buildings that were built in some of our communities that were made out of cinder blocks, and they see them dilapidating. And we say that is absolutely not what we're trying to do. We want to build beautiful homes for the people who already live and work in your community and for their families. And so by way of being able to tell the stories of the colleagues that have inadvertently from the hospital started living in some of these developments that we've done, by telling stories of the way that we've engaged the community around helping us develop the housing, or that we want them to develop the housing, by showing that we as a healthcare partner are committed to staying for the long game alongside these housing developments, offering services, being available to the developers, the property managers, the resident services coordinators. We're showing that we're really in the game with these rural communities, that we're not just going to throw up a building and book it out of town, that we're really there to create community and create a long-lasting investment that's going to impact everybody. And so we spend a lot of our time telling those stories and using our why and sharing our data to help people understand why affordable housing is deeply needed, but also deeply reverent and can be incredibly beautiful in their communities as well.
Thank you, Rebecca. And we do have one question. It's very specific, so I'm going to go ahead and ask it now before we get to AZ, which is, did the investors get a return on investment? And if so, how much?
No, so in this land trust, they were done as contributions. So all of the dollars went directly into it. There's not a specific return in these. Everyone who contributed to the land trust were with the understanding that you're contributing the money and you're giving it as a gift. And in fact, as a health system, if you speak health system speak, we did it as a community benefit as part of our IRS 990. And so we were able to use it as a community contribution directly towards that land trust. We do, however, share stories on the regular. LEAP puts out an annual report with beautiful stories and photos of the homes and talks about what people have been able to achieve and have been able to do ever since then. There was a really lovely story of a young family who wouldn't have been able to purchase a home, but the mom was able to become a young stay-at-home mom with the 2 kids, and dad has now opened a beautiful organic local coffee shop, which he would not have been able to do with the funds had he not been able to purchase this gorgeous home for himself and his family and pursue a new local business opportunity in our community. So I know that that's squishy and not like a specific dollar ROI, but it is still the stories and the important part of why we do this and what gets other funders and community partners excited about engaging in these projects with us.
Thank you, Rebecca. And I'm going to go ahead and pass it to Jen, who's going to facilitate the rest of the panel.
Great, thanks, Ashley. I'm going to bring AZ back into the conversation, and I think AZ has been nodding a lot, Rebecca, with your comments, because there's so much synergy in the work that's happening in Wisconsin from what you're describing in your work in Idaho. So, AZ, you're coming from a different position as a public health leader and specifically trying to leverage from a backbone role the multi-sector approaches. I'm curious if you alluded to this in your introduction, but I'm wondering if you could go a little bit deeper on your role specifically that public health has to play in housing work, and how have you approached this through multi-sector partnerships for policy change? You talked a little bit about some of the different sectors that are involved. I wonder if you could go a little bit deeper in that.
Yeah, so public health does have a lot of core capabilities that we can bring to the table. So I mentioned kind of convening and bringing to the table and facilitation and partnership building. That's absolutely something public health is good at. We're also really great data gatherers and analyzers. So that's something that public health has been able to offer. We're also pretty dang good at connecting larger organizations with members of the community who might be potentially impacted by these policy level decisions. So maybe we know a WIC client that's really been struggling with housing, or maybe we know of a reproductive health client that maybe we could bring forward and remind them, there's a public meeting about this topic. So I think we have some core capabilities as non-housing experts that can really be relied on. And I think one of the ones I didn't necessarily anticipate that we would be called upon, but that I think has been really important, is helping reframe the conversation. Like Rebecca mentioned, the term affordable housing immediately puts some community leaders into a panic because they think, for some reason, they think it's people from the Twin Cities coming into our community and draining our community of services sometimes. And that's not what attainable housing is about. It's really about supporting people who are already in our community to own their own home, to not be subjected to overcrowding situations, to build wealth in their own communities. And I think reframing it to employers as workforce housing or housing that supports the workforce has been really impactful. We cannot hire nurses, school teachers, police officers in our community because of sprawl happening from the Twin Cities has made housing in some of our communities just unaffordable for people that then work in our communities and receive our community's wages. And that, I'm a health officer, but I'm also an employer, right? I supervise about 20 people. I know the struggle of putting out a job offer to a public health nurse and her saying, AZ, I'd love to work for Pierce County, but I'm going to have to turn you down because my husband and I can't find a home. And I know employers in our community, from school districts to the cheese curd factory to UWRF, have all experienced employees not being able to find housing. So I think that was a call to action that everyone heard and really was able to digest as a non-political issue and come together in more of a multi-sector approach. So I view myself as a convener, as a relationship builder. I'm never going to be the investor, but heck, I can analyze some data and help come up with some communication material. So that's kind of how I view local health department's role in this conversation.
I think just jumping off of that, one of the things that I heard in the coalition meetings that we participated in was really taking affordable housing, reframing into workforce housing, and reframing into essential worker housing. Similar to Rebecca, what you were talking about in terms of attainable housing. I think essential worker housing was something that really jumped out as resonant for the different groups. Have you found, AZ, that has been consistent across the group of stakeholders that have come together to create sort of new narratives around housing?
Yeah, I mean, again, I think we're just beginning our journey, but helping people understand that, all right, here's the average rent for a 1-bedroom apartment or a 2-bedroom apartment in Pierce County, and here's what your local childcare worker earns. Here's what your correction officer earns. Here's what your radiology specialist at the hospital earns. It's not enough to cover a 1-bedroom in Pierce County. And I think that was eye-opening for people to look at their own wage scales and realize, wow, based on what I'm paying my employees, market rates, they cannot afford housing to live in this community. So yes, I do think that I'm hesitant, like Rebecca said, to always use workforce housing in replacement for affordable housing, because people who aren't working deserve housing too. And it is a foundation. But yes, I do think that reframing around essential worker housing has been something that's depoliticized the conversation about housing.
Thank you for that. I have a set of questions for both of you. I think I'll start with AZ. You both have mentioned the role of community engagement and attention to community engagement in driving the work that you're doing. I'm curious if you both can respond to these questions. One, how has the community responded to your role as a health system leader, working to increase housing? And then how are you thinking about deepening your institution's commitment to community engagement, whether it's in the decision-making practices or the implementation of housing projects, or if it's in policy advocacy? How are you thinking about going even further in your community engagement process? AZ, let's start with you, and then we can shift to Rebecca.
Sure. So I will say that in the start of this, there was some stay in your lane, COVID lady reaction to me trying to bring some stakeholders together around housing, because I think no one really knew about what your local health department did in Wisconsin until COVID. So there was some confusion about why we were involved. But I think that vital conditions framework that Ashley shared on her PowerPoint was a really important place to start, to say, yeah, I do care about COVID, and I care about tuberculosis, and I care about, drunk driving, but I also care about affordable housing, and this is why. And sharing some of the literature about the connection between health and housing was really helpful. We've really focused on deepening our presence in the community and holding space for community collaborations following the pandemic. It's not perfect. We work on it every day. And I think right now we're on that community spectrum of ownership that Ashley shared. We're more at the involved stage and working towards that building community to ownership. And one of the things that we're working on to do that, to move us along the continuum, is we recently provided grassroots advocacy training to our community partners in the hopes that they will become our grassroots advocacy arm around issues like housing. I think having, if there's a community meeting about ADUs in our community, I'm just going to be one voice. And there are definitely political connotations attached to now being a public health director in Wisconsin. But man, having a hospital CEO stand up next to me, who's viewed as a very influential community leader, very fair-minded, a huge employer, That's incredibly powerful. So I think building those partnerships really give us a chance for um, maximum impact when it comes to policy. So I think I'll always continue to be an advocate, but it can't just be Pierce County Public Health, which is why these partnerships are so incredibly important.
Thanks so much, AZ. Rebecca, would love to hear your thoughts on community engagement, stakeholder engagement, and how you're thinking about deepening those in the work that's forthcoming.
For sure. I'll start with a little bit about how has the community responded to St. Alphonsus being involved in housing, and it's actually been really positive in most cases. It was actually really fun a couple of years ago. The first time I actually went to the Idaho State Legislature and was there as an advocate to share data. So at St. Alphonsus, we screen our patients for their social needs. So we ask them about their housing status and food needs and other things that they might need. And we have a whole process that we connect and refer folks with community health workers through that. But I use that data to reinforce the community health needs assessment data that I have to specifically say, in 1 year, we had 877 requests for housing assistance as a hospital. We're a hospital. We are not the folks you go to for rent assistance, but we had 877 requests. And of that, I was able to stratify the top 3 things people were asking for in terms of rent assistance, finding alternative housing, and assistance with thinking about how to move into home ownership. And we were able to share that at the legislature to advocate for rental assistance funds during COVID. And when I stepped in and said, hi, I'm Rebecca from St. Alphonsus Health System. As a hospital, we've had 877 people ask us for housing assistance this year. It perked up the ears of people who weren't always listening to the traditional housing advocates. So by having the hospital step into the space and say, hey guys, this is an issue. And hey guys, on our health needs assessment, where you're used to me talking about diabetes and chronic disease and asthma, I'm talking to you about housing. And I'm telling you that all the efforts and work that we put into making our patients as healthy as we can inside our walls, it makes zero difference if we have to discharge people to their cars. And so people really started saying, wow, if the hospital's paying attention to this and investing in this, then maybe this is a big deal for us. And then it pivoted quickly into, hey, part of our healthcare workforce shortage is, to AZ's point, we can't bring providers to our state if they can't afford to live here. And that happened daily. So the community has responded well. And I think it got people's attention in a way that other housing advocates didn't. And now we've got a lot of people whose voices are in the mix around housing. So it's been a good thing. In terms of community engagement, this is something we're in the learning process of, being fully vulnerable and transparent. I would say early on, we did things based on our data that we felt were correct. So we went in and we built housing and we started adding on services to that housing that, based on the needs assessment, we thought were right. But what we've since learned is populations are all different, and people from neighborhood to neighborhood, building to building are different. And we now do listening sessions. So we are deep and intentional with assuring that before we even bring housing or providers in to talk about, are you going to do telehealth? Do we want to do behavioral health? Do we want a food pantry here? Do we want to do some sort of a transportation project or community garden? We're talking to the potential residents and the neighbors. It's really important to involve the neighbors around the development. But with the Build Pay At project that we're going to be doing for the Build Health Challenge, we actually specifically wrote in for the first time for our state. I recognize others do this, but we're newer into it. That we want to cultivate community champions. So we have stipends, and we intend particularly to do some outreach with our Hispanic and Latinx migrant farm working populations, which are our larger population contingents in the Payette area, where we have funding, where we intend to bring people in. We want to do some specific advocacy training to help them reach deeper into their networks and their communities and their churches and their schools and their folks that they know, to bring them together to help us co-design the housing that we want to build. So they will help us with architectural renderings. They will help co-design what it looks like to make sure that culturally a new development looks correct in Payette, Idaho. And then we'll also be having additional engagement opportunities around services before we ever make an MOU with any provider to do anything. And then the third thing we want to do is we are hiring a coordinator of and from the community to be our resident services coordinator that will be attached to the project ongoing to continually revise, talk to the neighbors, talk to the residents about, what do you all want? Is this working? Is counseling offered at 6 p.m. on site by your housing what you actually actually want? Is that working, or do we need to pivot and do something else? So we're really taking to heart this idea of community engagement from the beginning, building community champions, and trying to figure out how to train up folks in their communities, especially from our BIPOC and Latinx community members, to really help them learn how to use their voices and advocate, not just for housing, but for whatever else they want in their own best interest moving forward when this project has wrapped. So we're trying to learn how to be more intentional about it.
It's really exciting. Both of you are sort of at this pivot point in a lot of your work. So just really appreciate those insights and those aspirations as you move forward. Thank you both for providing at least a top level view of some of your work. I'm going to turn it over to Eric, who's going to land us in Minnesota right now.
Well, thank you both. The level of content was tremendous, so I really appreciate the details that you did bring in a short period of time. It's always hard, but it was very rich, so I appreciate it. There's a great examples of very intentional work coming together to advance health equity through housing. So it was inspiring to hear the partnerships that you've developed, and really about reshaping the narrative around housing focused work. So I'm very appreciative. So we're going to switch gears now and talk more about workforce housing using some Minnesota examples. This year, GMHF, we kicked off a Housing and Health Equity Fellows program. So this is 30 fellows, teams of healthcare professionals from 6 of the top 10 health systems in Minnesota: Allina, Blue Cross, Centracare, Children's Minnesota, Essentia, and mHealth Fairview. And they're coming together to identify those opportunities, the strategies to use investment resources to advance health equity through social determinants of health and housing in particular. Now, in our first couple of meetings with these fellows, workforce housing was quickly raised as a top priority for them. First, because workforce housing is a need identified as an employer of these institutions, right? And second, because healthcare is experiencing a workforce shortage more than any other sector in the economy. So the development of more workforce housing for healthcare is a way of possibly to attract workforce and retain workforce in communities that have a shortage. Last year, when we reviewed the location of housing development that GMHF had a hand in financing, over some 2,000 units actually, we discovered that 90% of those units were within 2 miles of a healthcare facility or a healthcare employment center. So proximity is another way that housing and healthcare intersect. And the more pronounced focus on this connection could produce increasing benefits for healthcare institutions, for workers, for patient care, and for community health. So next I want to turn over and introduce John Rocker, who's our Greater Minnesota Housing Fund Director of Lending. And John's going to share a couple of examples of housing projects and ways that healthcare could be involved in catalyzing housing in their community. John?
Thanks, Eric. And I think if you can just pause right there for a second, Jay, the slide says catalyst for workforce housing, but as Rebecca so clearly pointed out, it could say catalyst for workforce housing, senior housing, permanent supportive housing, and all other attainable housing. And so I'm going to go through a few examples of projects in Minnesota that has had combining of health and housing. But a couple of the first two are actually more supportive housing than traditional workforce housing, just because to show the range of housing, and also because a lot of the financing tools are the same for whatever you're trying to build. So you can go to the next slide, Jared. I just wanted to point that out, and thank AZ and Rebecca for laying the foundation so well about the importance of all this that I can just now talk about how we actually got some projects built. So the first slide here is just a little bit about Greater Minnesota Housing Fund, formed in 1996 by Warren Hansen. We are a statewide Community Development Financial Institution, or CDFI. Our focus is on affordable housing. Almost all of what we do is in multifamily housing, though we do have some involvement with CLTs and some single family construction. But the bulk of what we do is in multifamily housing. Our name, Greater Minnesota Housing Fund, indicates where we started from in Greater Minnesota, not including the metro area of Minneapolis, St. Paul, and Wisconsin now. But as the need has grown in the metro area here for CDFIs to come in and provide affordable housing, we are now active in all counties of the state. So with that, we can move on. The next slide, I don't need to talk. Jared, can you go to the next slide, sorry? I'm not going to dwell on this because, as I said, Rebecca and Izzy did such a good job of talking about how to build support. And I just want to echo that health organizations are great conveners. They can point to the need that they have in the community and they see in the community, and they don't have to be experts in developers. I know there's some developers on this call, and they know the financing. They know how to make the projects work. What their need is community support to build what the community needs, and then the financing to make it all work. So really being the champions is the first main step. So I think what we found here, in addition to being that champion and organizing and working with community leaders and other employers to set up shared goals, we found that's really helpful to specifically identify like the number of units, the type of units, and put some time frame on it to kind of get the community energized around a specific goal, whether it's 20 units of CLT, or we need to build 500 units of all income levels in the next 5 years. I think we found that it really helps get people motivated to take it out of the theoretical realm and get it down to the number of units and types of units. And there's some also people I think on the call from some HRAs or EDAs. They know the local community and they know the way to get things built, and they have connections to developers. So they're a great organization to champion these and lead these things through it once there's community buy-in. So I just wanted to throw it out there. And a lot of this, once there's buy-in to do it, it's about getting the costs down, right? So to get the cities to commit to donating land, or somebody else to donate land, to provide tax increment financing, or to pay for the infrastructure necessary to actually start building the buildings, are kind of keys to the economics of getting things to work, and where the local community can come in and play a big role in that. Let's go to the next slide. So these are just some examples. We've heard about different ways that healthcare organizations can invest in workforce housing. I think the donating land, direct grants, short-term loans, most of these are covered in my example, so I'll talk about them specifically as we move on. I think the ones that probably aren't mentioned in the examples here are a direct purchase of low-income housing tax credits, which would be a for-profit hospital, and that has been successful, and it does, there is a rate of return attached to that. So it's a 15-year investment, but for certain for-profit entities, that's a way to invest in supportive housing or workforce housing and make a return and have an impact in their local community. And then master leasing of units I put on there just as another way of stabilizing income for a property, especially if it's for your own workforce, if it's a healthcare organization, anything that can create some stability in the cash flow of a project will help the projects get built. Sometimes it could be used as, in lieu of putting people in hotels or corporate housing, as a way of providing maybe temporary housing for employers while they find permanent housing. But at the same time, it's stabilizing and helping to for people like me to underwrite projects because we know that that income is there on these units. So if we can move on to that, I'll start walking through some specific examples and leave time for questions. The first one is the Mitchie Veterans Home. So this is senior supportive housing, and Sanford Health realized that they had excess land, and there was a great need for veterans housing, and so they kicked off a campaign, and it took years to put together. So I think one of the other things to realize is that these things don't happen quickly, oftentimes. And so Sanford Health donated the land and got the train moving, and then the city became more engaged. There was an application to Minnesota Housing Finance Agency for additional funds. The Department of Veterans Affairs contributed VASH vouchers to the project, and then there was a requirement for the local community to match the federal funds. So it started with donation of land, and probably over 3 years they've cobbled together the financing to actually get it built. So that's not every hospital or healthcare organization has excess land, but if you do, it's a way of contributing without coming out of pocket for more money. So it seems like a relatively simple thing to do. We are working with another hospital in rural Minnesota now that also has excess land, and they would like workforce housing built. They're having trouble attracting their workforce, and they're hoping if they can contribute land that they own, that will help make it feasible and bring a developer into the community. So if we move to the next one, this is another supportive housing project. But again, it shows the multitude of ways that healthcare organizations have contributed to this. This is the St. Francis Apartments. It was a motel, as you can probably guess by the picture. And the hotel shut down during the pandemic. It wasn't being used much before then. And within a block was the Churches United of Ministries homeless shelter, and they were overflowing during COVID, and they needed a place to isolate people during COVID. And so this opportunity came to buy this hotel and use it as permanent supportive housing, specifically for the seniors that were in their shelters now, that were most at risk. Chum had the vision and strung together a lot of different sources of funding. Duluth HRA contributed money. St. Louis County Blue Cross and Blue Shield provided a grant to Chum, which was put into the project. Greater Minnesota Housing Fund, we provided the first mortgage for the project. That got them to close. It's 40 units of a 45-unit hotel. They kept 5 units aside for offices, for supportive services clientele, and also to do telehealth. Chum didn't want to be a long-term property owner. They wanted to provide the services. And so after they acquired it and stabilized the property, St. Luke's Hospital came in and took over ownership of the property, and Chum continues to be the service provider. If we move to the next page, now we're getting a little bit more into workforce housing here. The goal of this project is really to create workforce housing, but specifically to kind of use the anchor institution strategy of trying to build workforce housing near major medical facilities. And so this is a project now under construction along the Greenway in Minneapolis, in South Minneapolis. It's 86 units of affordable housing. 11 of those units are permanent supportive housing for persons experiencing homelessness. And it was being financed with tax credits and bonds. So pretty conventional financing. HUD First Mortgage, the city of Minneapolis contributed a lot of money to it. We are providing the bridge financing during construction. And part of the way we were able to make this work is that Allina is providing us with low cost money, which that we can we can do the underwriting, we can do all the work that's involved in putting the money into the project. But by them providing us low cost money that we can pass through into a project, we've lowered the cost of the project. They don't have to be the real estate experts, but they can rely on us to put the money in the project, help create this housing. And when this one is done, we will take that money and put it into another project in the neighborhood and keep doing that for 5 years or so. So this is a kind of an example for a healthcare institution of, it doesn't always have to be a grant. It's great for the project if it is, but it can be 5-year money with some return, and it can still contribute a lot to creating affordable housing. And if we move to the next one, Maplewood Apartments, this is, sorry, I lost you guys. This is actually an example of one of Greater Minnesota Housing Fund's new initiatives called our Housing Impact Fund, which is really designed to fill in the missing middle of that workforce housing. So it's, especially for, I think, we've found a lot of interest in this in Greater Minnesota, where they really want a gamut of price points, or from market rate housing to deeply affordable and things in the middle. And so what we've created is this second mortgage, basically, that allows these projects to work. And without getting into the details of the financing, it's a mixed income project. It's new workforce housing, and we are measuring health outcomes by doing surveys using success measures. And so part of the appeal too is that we can do some longitudinal surveys of the residents to gauge health impacts of stable housing. And in this case, the way the healthcare organizations contributed to these projects is via our Housing Impact Fund. So they are contributing money to the fund, which is then investing it in these projects. And I noticed there was a question earlier about return on investment. And again, this is more long-term financing. This is 10 to 15-year financing, but again, it's a loan into the projects, and we're pretty flexible. But we think we make it work if it's 3 to 5% return to the organizations, that we can turn that into successful workforce housing. And we've got first 3 projects. One's completed, 2 are under construction. We're on our way to a $100 million fund. We've got about the first $25 million in the pipeline right now. And so we are hoping this, whether it's building new or rehabbing existing NOAA housing, that this will help fill in that need, and then leave the scarce resources for the deeply affordable projects. Because as we know, we need a range of affordability. So if we can build this without deep government subsidy, then we can save that for the supportive housing projects that need the deeper subsidies. And then lastly, this is a project that's kind of a combination of the two, and this is up in Grand Rapids. So this was a 48-unit project. It built in 2 pieces, but as one project. There's a townhouse component, which is typical workforce housing, and then there is a 20-unit supportive housing project, half serving persons with mental health disabilities or chemical dependencies, and the other half for formerly homeless. And those 2 wings are joined by a central kitchen and service area. And Northland Counseling Center is providing the services and operating support for this project. So part of making this project successful, even though the capital came from tax credits and from Minnesota Housing Finance Agency, Northland Counseling Center's ongoing service support is really what makes this successful and work. And I think we were just up in Grand Rapids, which is a place where the message of needing affordable housing and a range of employee housing was very apparent. Grand Itasca Hospital and some other major employers were all talking about difficulty in finding employees because there's no place to house them. So I think this whole group, it's been said better than I am saying right now, but it's really important to get the healthcare institutions just involved in stating the demand, and getting the people behind it, because it's a big voice to get things done. So I will stop there and turn it back to you, Eric.
Thanks, John. And there's a growing number of these sorts of projects where we're seeing these sort of partnerships come together. So it's really exciting. What I want to do now is open it up for questions. We've got 15 minutes or so. I invite people to turn on their camera. We like to see, gorgeous faces, and so you don't have to, but I invite you to if you'd like to. And if you'd like to ask a question, it is open mic. If you want to ask a question, either raise your hand or come on and speak. Before you can be thinking about questions, but I'm going to ask a question and bring AZ and Rebecca back into the conversation. I'm curious about what are the external forces in the healthcare ecosystem that are influencing you toward social determinants of health and housing. So I'm wondering, what are the real drivers behind this? And is this going to be a continued trend, and why so? Rebecca, you want to start?
Sure. Yes, this will be a continued trend. As I mentioned, we started the Housing Land Trust was our first project, started 4 years ago. We have completed 3 housing projects, 1 early childhood education center. That was at the community Baker City, Oregon, which is a frontier community, actually needed childcare more than housing at the time. So we've completed 3 housing projects, 1 childcare establishment, and now we have a pipeline of 4 more projects across rural Idaho into that Eastern Oregon area. So it will continue to be a focus. Additionally, we will continue to focus on the social determinants. So we also have project and community partnership work we're doing around transportation in rural communities. Because guess what? There's not public transportation in our rural communities, and we've got a lot of provider deserts where we have a number of retired and older adults populations who can't get to specialty healthcare services that they need in another community. So we are getting really innovative and interested in how to do really unique transportation models collaboratively and collectively. So we're investing in transportation. We're doing a little bit deeper dive into childcare. I mentioned that intentionally because our workforce can't work if they can't find affordable, high quality and attainable childcare. So we're doing some work in the early childhood education space as well. And then of course, food. Food access is always a big deal. So we're doing some unique things around mobile pantries on site in clinical spaces where we know that we have higher percentages of patients that are screening positive for food insecurity and some other things. So we will really continue to do that, because as I talk from the community health perspective with my senior leaders at the health system, they recognize that healthcare access and healthcare is only about 20% of the 100% of what makes a person healthy. I think we've all seen that graphic, right? That the other 80% is made up of the physical environment, the social determinants or influencers of health that you live in, and your healthy choice behaviors. And I always argue that the choices we make are shaped by the choices we have. So it's my job to work in the community to offer people the infrastructure to have access to healthy choices. So I would say, yes, we're committed. We will continue to do our community health needs assessments every 3 years and check and see, is housing still the pulse? Is it food? Is it childcare? Is it something else? Is it a different kind of housing than what we've been doing? So we'll continue to make that an effort. But I think those social determinants as the drivers of what's causing people to utilize healthcare, and especially utilizing emergency and expensive acute healthcare, will just continue to be a trend for us. So it's not a flash in the pan. This is something that we are committed to for a long time coming.
That's great. AZ, could you maybe comment on that from the public health department angle? It would be really, one, I haven't heard of many public health departments sort of leading in this space, so it's great to see, but I'm wondering, why are you doing it? Is this a trend within the field of health departments? Or again, are you sort of a unique player in this?
I don't think I'm at all unique. I'm just good at self-promotion, I think. And I was smart enough to call Jen at Build Healthy Places Network and get her to contract with us. So no, I think health departments are supposed to be directed by community voice, right? Our work is supposed to reflect what our community is telling us are priorities. And I think that if we're asking the right questions in many communities in Wisconsin, housing is going to be raising to the top. And I think for the first time in a long time, health departments are being encouraged to do their community health assessments with a broader lens and asking broader questions that could result in answers such as childcare and housing. I think that I think that a barrier to continuing this work is the way local health departments are funded. Wisconsin is tied for dead last in the nation with Nevada for funding local health departments with state funds. That I have to cobble together funds that are very specific scopes of work attached to them for every position I have in the health department. That does not leave a whole lot of flexibility to try things that are community specific. So this is kind of stuff that I do for the hours that I work over 40. And so I think that advocating for more flexible, sustained funding at local health departments will be important for sustaining this leadership role. But we had our annual public health conference in Wisconsin last month, and I have never heard so much talk about housing before. And I think that that's fantastic. I think I'm one of many that are having this very same conversation across the state and across the nation. But again, to sustain it, we need to think about how we're supporting our local health departments.
Thank you.
Just one more thing, if I can, that I was thinking of as AZ was talking. So the financial situation is real, and I like to call out that elephant in the room. And as somebody who works for a health system, it's very acute. The ability, that $250,000 I contributed into the Leap Land Trust, I could not put in today. I do not have that amount of funds to contribute financially. It just is not realistic for us. However, when I said I wanted to be a meaningful partner in housing or other social determinant work, I meant that in a number of different ways. We've been a lead convener in bringing partners together to talk about what are the realities. We have also led the charge in bringing other people to the table, whether they are kind of traditional thought partners and funders, or whether it's helping apply for LIHTC funds, which is not my world as the developers, but my letterhead and letters of support and letters of commitment into how we'll work with these developers is allowing them to get extra points and credit towards getting those extra funds. I'm also an advocate. I show up at so many city planning and zoning meetings for making zoning choices around ag land or other land being converted into residential, that advocacy is something I can do all day long with $0 in my pocket. And then finally, data. I collect data around the needs assessment, but also we collect that patient data that I mentioned around the social care screening that we do of our patients. I can aggregate that and tell people stories all day long of what people are asking the hospital for and what we can do. And so I just want folks to not feel deterred because I have had those moments where I felt like I don't have the money that I had 3 years ago to invest personally as an organization. However, I still show up, and I've still been really successful in being able to work with other community partners to cobble things together, to get scrappy, to use our relationships and find ways to continue to do this work, even when we're not flush with cash at the moment.
That is a real, hospitals in particular, right, are really struggling right now, but hopefully that trend will shift. So you are, Rebecca, a strong advocate. I hear you. I love that you're going to local council meetings and fighting for easements and things like that. That's wonderful. So what advice, do you have any advice for other organizations, community organizations that really want to engage with healthcare? Like how do you approach a large healthcare institution? What does that look like, and what any advice that you could give for how to do that from the perspective of a community? Maybe it's a local community development corporation, or maybe it's a local nonprofit that wants to partner.
I can tell you the way people started with us. The first people that started approaching us before we proactively went out and started seeking opportunities was people started coming to us because of our workforce. It's the WIFM, it's the what's in it for me. It's the going to the healthcare system and saying, in particular hospitals, we know you have a challenge with recruiting and retaining, not just your, entry level pay workers, your environmental services folks, your entry level folks, but even physicians and nurses and surgeons and specialty care folks. We're struggling to do that. So at the very least, you can start to appeal to health systems around their own workforce and then open it out. But also you can appeal to the social determinants. I think that's becoming enough of a point of conversation and broad enough in the vernacular with health systems to get them into it. And so many health systems now have community health and wellbeing departments, such as myself, or community benefit departments, where they have to put back so much into community, and they're looking for ways to do that. Whether it's because their community health needs assessments are telling them, or it's because they're starting to hear this bubbling up in their community that you can do all the work you want with the patients, but if they don't have a safe place to go back to, that's tough. So I think the workforce angle, talking about how the social determinants impact your ability to provide care, and then looking for the folks inside each health system who may already be starting to do this work. You just may not know who they are specifically, but community health doesn't just exist in a few of our health systems. It's becoming pretty standard book of work in a lot of systems.
Yeah, that's great. So we did get a question in the chat. I understand about workforce housing. What about affordable, intentional senior communities living together, deciding together, supporting each other, like co-ops? Isn't this a healthy alternative to costly, traditional, mostly for-profit institutions like assisted living? I'm wondering, maybe AZ, you might be able to answer that.
Absolutely. So we talked a lot about workforce housing because that is definitely something that our partnership put forward, but we are also very interested in affordable, high quality senior housing as well. I'm in Wisconsin, and what do we do in Wisconsin? We go to our cabin. So we have a lot of vacation homes in Western Wisconsin. And what we've been kind of shocked by is that a lot of homes are turning into rental homes, like smaller homes, cabins that could potentially be used for senior housing when they want to downsize their cabins. Now they're rentals, and people will pay quite a bit of money to come stay in Western Wisconsin for the weekend. So they're becoming rental housing instead. So yes, we absolutely need to focus on affordable housing. I think we try to work in partnership with our senior living institutions because we certainly don't want them to feel that we are stepping on their toes, but we have worked with some of our skilled nursing facilities to consider adding on additional units that would be lower levels of care and far more affordable. We have also worked with the city of River Falls quite frequently on some of their 55 plus senior housing that's been largely affordable and has been very successful.
That's great. So I really want to thank Build Healthy Places Network for co-sponsoring this, for their both leadership. They really do have amazing tools on their website. When I first started down this path, I did sort of scrounge through all of it to find stuff that I could use, and I found stuff. So it is worth it taking a look at. So thank you. AZ, Rebecca, and John, thank you for your time and presentations. So I appreciate everyone being here today. And if you are a community organization that hopes to engage healthcare in your work, please reach out to me, reach out to the Greater Minnesota Housing Fund. I think we have a slide that Jared is going to put up with contact information. And if you're a healthcare institution and you want to begin to get more involved in affordable housing, the Housing and Health Equity Initiative is here to facilitate these connections. And more I'm getting calls from out of the blue from a hospital in, towns throughout Minnesota that are sort of inquiring about how to go about it, and we want to be helpful. So please encourage you to reach out directly, or you could go to the website that's on here, and there's also a submit a story button. There's a mailing list you can sign up for. So I'd appreciate doing that as well. And thank you all for joining us. And we're going to wrap up, and we're right on time. So I'm happy about that. Sometimes we always run long, right? So thank you, everyone. And yeah, watch for our next event. There'll be another couple this year. So I look forward to seeing you all again. Thank you.